Dr. Juraschek, you noted cost and access as key barriers even after the intervention ended. How does that influence how we think about scaling this intervention into the real world?
Yeah, and this has come up quite a bit. And it's such an important question because that's really what we're trying to get to. I think with GoFresh, we really focused on trying to identify what are those groceries, right? There's so much talk about food as medicine that's so important right now.
Hmm.
But one of the fundamental aspects about it is, we say, oh, give people healthy food, but it's not always clear where the therapeutic targets are with that healthy food. And we were excited with GoFresh being able to demonstrate core principles that could be targeted with medically tailored groceries to optimize certain health parameters, in this case, blood pressure and LDL cholesterol. And we think that the principles demonstrated in DASH can be used in other settings for other programs. And this is really valuable because even you might say, maybe all of our listeners, they might not need assistance accessing groceries or purchasing groceries, but they might not know exactly what they should be looking for in terms of their grocery lists. Well, they can immediately apply GoFresh in their family situation and hope to achieve similar health benefits. So I think that that's useful right off the bat. I think beyond that, I think we establish kind of places for to think about with respect to policy that could potentially make and address the sources of or the barriers that make these healthy groceries less accessible. Some people have talked a lot about food subsidies and SNAP-like programs, and how can we take something like GoFresh and make it more cost-effective so that those programs can be used to provide apply GoFresh principles to achieve the health benefits with food subsidy programs. And many payers have adopted similar kind of food assistance strategies. Urban planning, I think, is another critical way to think about results from GoFresh, and how do we make these kinds of groceries affordable and accessible where people live so that it's not so challenging for families to enjoy them. Targeted food subsidies at the policy level, right? The idea that maybe certain types of foods, by making them cheaper, they may be consumed more and can achieve better health benefits. I think that's also another strategy that might be taken or could benefit from the knowledge generated by GoFresh. So I think there's a couple of different ways the knowledge can be applied. Even for programs, a lot of times we think about going to the grocery store ourselves, but many people, college settings, congregate living facilities, many people are dependent on others to purchase groceries on their behalf and prepare meal plans. Well, GoFresh provides some information that's useful to those larger programs as well. And so I think there's a lot of different ways that the knowledge from the study can be directly applied. We don't have all the solutions. We haven't worked out all the policy issues, and we know that there are a lot of dedicated policymakers right now really trying to evaluate, well, what's the best way for us to achieve more equity around healthy eating and achieve those health benefits for all. But I think GoFresh is really useful in establishing, well, these is a good place to start. And if we can figure out how to get this sort of strategy of groceries affordable and accessible, this could be a way that people can really achieve health benefits, not only for themselves, but also for their families.
Well, I can't think of any better starting point, or a building block as a base for this pathway. So coming to this, how has GoFresh shaped your next steps? I know you mentioned that there's another trial that you're thinking or working on.
Yeah, so we're really excited about GoFreshRx. Was run at the same time, but the main difference is that it was a population with treated hypertension, but otherwise everything else was the same. So we'll have a lot of opportunity to kind of compare and answer that question that you brought up about, okay, well, what about in the context of medications? Do we get the same health benefits? And we're really excited to prepare that manuscript and abstract for dissemination in the coming months. At the same time, we were supported by the American Heart Association to scale our strategy more broadly. And so now we're active. We have another study called GoFresh Southeast, and we are actively recruiting participants in Tennessee, Florida, and Georgia, in Nashville, Atlanta, and Jacksonville. We are, it's a modified 1 month version of the program, so it's a little leaner, but anyone in those areas can participate. So we've really broadened the eligibility. We have home visitation, so folks are going to, we have health technicians that go to the home to measure blood pressure and perform labs, so people can participate in the program at the convenience of their home. Groceries still get sent in the sort of GoFresh strategy to individuals' homes for their families. So we're really excited to extend what we thought was really well received intervention to those 3 states in the U.S. And our hope is to continue to expand more broadly. And we've been able to establish a consortium called GoFresh World with countries representing all the inhabited continents throughout the world. We're hoping to continue to increase our partnerships. But the goal there is to really get universal standards in grocery ordering that really transcend culture, that can be applied everywhere, right? So we don't have to say, okay, well, what's the version of Dash that works here or there? But really, this is the principles that you can apply wherever you are at your grocery store. And so that's something we're really excited to achieve. And then we've been thinking a lot about ways to scale the algorithm in grocery ordering strategy that was done with a dietitian. And we've been talking with various different partners about whether or not a platform might work that could program in the strategy, the ordering strategy, so that a care team could prescribe an evidence-based nutrition targets that get linked with groceries sourced from a local grocery store near the patient, that they could immediately use to order and fill in their cart, and then go either pick that up or have it brought to their home, and then maybe have a plug-in for payers to subsidize utilization of the groceries or interactions with the platform in order to reap the benefit of a healthier group of clients, right? So that's our kind of vision or hope. We're still sort of talking about how to make that a reality, but we're excited that it could be a lot more scalable and cost effective in the future.
Yeah, absolutely. And I think a strong base of this is education. So you're educating everybody, the people who are, this is what the DASH diet, this is what you can do. These are the
Yeah.
ingredients. And this is empowering the people themselves to make the right decisions for their, everyday life diet. So this is amazing. I was thinking, if there is only one key takeaway about addressing hypertension disparities through nutrition and structural interventions like GoFresh, what would you want the clinicians and trainees to remember?
Well, I think we shouldn't give up on nutrition. I think there are so many great ways to treat hypertension today, and even exciting procedures in many ways. But even with all of our knowledge in terms of pharmacologic agents and choices, there's the fundamental reality is our healthcare interventions are often reactionary. And as a result of that, they can come late to people when they already have had irreversible damage from high blood pressure. They can be incomplete, right? And so folks who don't get adequate screening, don't present early enough, can't afford medications, or don't have a stable way to get medications, they can have inadequate treatments. And the reality is, with food being so broad, often we find problems so late that there will be irreversible premature deaths and disability that really cannot be rectified. And so a reactionary strategy will never be able to keep up with the growing pandemic of hypertension and cardiovascular disease risk factor illnesses throughout the United States and the world. And so a prevention approach is really critical, and finding ways that can allow everyone to take advantage of prevention even before they have to present to the doctor's office, I think is really critical if we're ever going to close the gap in terms of disparities in health outcomes. So don't give up on lifestyle. I think it's challenging. I think there's a lot of policy things that we are working through as a country. I'm excited about more and more discussions in these areas. But I think it's never been more important that that we identify the best ways to eat, and we make those ways available and accessible to everyone. So
Yeah,
thank you.
absolutely. Prevention is early intervention. So this is very important, not just to depend on pharmacological management and therapy. So acting early on rather than reacting is absolutely the way to go. Dr. Juraschek, thank you for your time and for all the work you're doing to address the inequities in hypertension. I appreciate it, and I'm so happy to have met with you today. Thanks for sharing all the details, and I'm excited to see the upcoming trial results and what you're doing as well in this field.
Well, thank you so much for the privilege to be here and the opportunity to share our work and speak about something I'm so passionate about. So it's such a pleasure to meet with you today. Thank you.